Good afternoon, ladies and gentlemen. First of all, I want to take the opportunity to thank all of you for taking time out of your heavy schedule to join this scientific discussion. My name is Jonas Mate, and I strongly believe that most of you certainly knows me. I'm the country, I'm the currently the country lead for Boringa Engelhem in Ghana. And as a research driven pharmaceutical company, we believe that we need to share some of our data with the HCPs in Ghana and beyond Ghana. Currently, when you look at the global scene, most of the guidelines, have been updated, and not only in the space of diabetes, where we strongly play, but in heart failure, hypertension. Virtually almost all the guidelines have been amended. This afternoon, we have the opportunity to engage one of the consultant cardiologists to look at the issue with hypertension. I remember back in the days when I started my career in AstraZeneca as a young medical rep. I remember very well, I met these practitioner, and he said that you guys don't know what you are talking about, because he believes that you can combine two calcium channel blockers to drive patient blood pressure down instead of using different classes of antihypertensive. And I was a bit alarmed, what is really happening. Of course, hypertension is quite an old disease, let me put it that way, if you permit me. But still, we are seeing a lot of patients with hypertensive heart diseases. And the cardiologist will tell you that most of the hospitalization for heart failure is largely driven by hypertension, apart from diabetes and so on and so forth. So I strongly believe that this is something we really need to look at to address, the disease burden, to reduce some of the fatalities we see in our practice on daily basis. This afternoon, we have a cardiologist, like I said, someone you know already. She doesn't need a long introduction. She's a consultant cardiologist who has been working at the National Cardiothoracic Center for many years. She's no other person than Dr. Mrs. Jan, who would do the, justice to the topic and help us navigate our way through the management of hypertension to reduce both the cardiovascular morbidity and mortality we see in our clinics. Ladies and gentlemen, kindly help me introduce or welcome Dr. Mrs. Jan. Thank you very much.
So, thank you very much, Jonas, for your kind introduction. And so, we're going to talk, as he said, is a disease that we already know. We know a lot about the disease already. It's not anything new that we're going to talk about. And still, in spite of it being an old disease, we still have a lot of patients suffering from the disease. Many of the patients are dying. They're dying from hypertension related cardiovascular morbidities. And you wonder, with all that knowledge that we have about hypertension, why is it that the patients are still dying? What is it that we're doing wrong that we can't get the patients to be well controlled? And so, can I see my screen, please? Can you hear me? Hello? Hello? Rachel. Hello.
Right. Good evening once again to all our participants. And my name is Dr. Agibit Baini. I'm with Britannia Medical Centre. I'm the head of clinical services. Um, Britannia Medical Centre is barely 4 years. We are 4 years in January. Um, and we are excited to be part of this all important CPD. As a facility, we started off generally as a GP service-based facility, but over the few years, we've grown extensively to incorporate other areas of medicine in our practice. I.e., we are currently doing obstetrics and gynae, internal medicine, general surgery, pediatrics. We have orthopedic surgeon and a general surgeon on board. We have plans to incorporate laparoscopic surgery in the near future. But for the purposes of our gathering this afternoon or late evening, I come to you as the head of the Family Medicine Division of Britannia Medical Centre, where we try to run weekly hypertension and diabetes clinic. And I must say that since we started this year, it's quite interesting to see the number of cases we are picking up in terms of newly diagnosed hypertensive and diabetic. And I'm worried because we are seeing people in their middle 30s, late 30s coming up, undiagnosed and hypertension and then diabetes, which is really of much concern to every doctor. I'm sure the story wouldn't be different from colleagues who are practicing elsewhere within the country. So this CPD really should excite all of us. Should be a learning forum for us to add more arsenals to the care we give to our clients. I hope that we all learn something new and incorporate into practice. Thank you, and let's enjoy this CPD.
Thank you very much, Doc.
I don't get the site to be able to see the contents of the screen.
All right. So, hello, Dr. John. Are you set down? Are we good to go, or do we still need to give you a few minutes? Hello, Dr. John. Are we good to go from your side now?
Hello. Right. So I am now going to the present. I go to the slides. I press the hypertension. It's already loaded. You see, it's there. I can see it. Yes, but still it's not on the, okay, now it's on the screen.
It's on now, so I think we can go ahead. I would like to apologize for the technical hitches, but I think we are good to go. Thank you to our cherished audience, and over to you, Dr. Mrs. John. Let's proceed. Thank you.
All right. Thank you, Jonah, and sorry again for the delay. So we will go right ahead and start with the presentation. This is my disclosure. And hypertension is the most prevalent cardiovascular disorder globally. And according to the WHO, it affects approximately 1.2 billion adults between the age of 30 to 79 years. It is a preventable cause of cardiovascular disease. And unfortunately, today, the prevalence in 2023 is still increasing, and that is especially in the low and middle income countries. And many patients are underdiagnosed and still undertreated. So, with so much knowledge that we have about hypertension, we are still not able to manage the patients properly. We know that hypertension is a very powerful risk factor. And in relation to other risk factors like high cholesterol, overweight, obesity, hypertension is the main risk factor causing cardiovascular disease, morbidity, and mortality. Now, many of our patients with hypertension have hypertensive heart disease, and it is rather disturbing. So many of these patients come for echo, and instead of having a normal heart like what is on the left, many of these patients have echo images like the image that we see on my right. And that is, we see these patients have significant left ventricular hypertrophy. And we know that this is going to give rise to heart failure in the near future. How do we define hypertension? So just a reminder, we know that it is repeated office systolic blood pressure greater than or equal to 140 millimeters of mercury and or a diastolic blood pressure greater than or equal to 90 millimeters of mercury. This definition, however, is a bit arbitrary because hypertension is related to cardiovascular disease. And we see cardiovascular and renal comorbidities and even death in patients who have systolic BPs greater than or equal to 115 millimeters of mercury and diastolic BPs as low as 75 and higher millimeters of mercury. So therefore, there's a close relationship between hypertension and cardiovascular events. And so there's no clear-cut BP at which we can say this patient has hypertension. But we need to make the medicine simple. We need to make it very easy for doctors to manage patients. And so that's why a cutoff BP value has been used to define hypertension. But better definition of hypertension is we can define hypertension as the level of blood pressure at which the benefits of intervention, and here we're referring to both lifestyle changes and pharmacological treatment, exceed those of inaction. So it is the BP at which the patient will benefit when we use treatment than we don't do anything at all. We can define it also as a progressive cardiovascular syndrome that is associated with hypertension-mediated organ damage. So we define it as a progressive disease that forms what we call the cardiovascular disease continuum. And this continuum begins with risk factors, where hypertension is a major risk factor. We have other risk factors like dyslipidemia, like diabetes, obesity. So these risk factors, they all cause changes in the body. They cause an increase in oxidative stress. They cause vascular remodeling of the heart. And this, in the long run, is going to cause atherosclerotic disease, heart disease. It's also going to cause left ventricular hypertrophy. And once atherosclerosis sets in, then patients will develop coronary artery disease, cerebrovascular disease, peripheral artery disease. And all these changes is going to cause remodeling in our heart. It's going to give rise in the long run to congestive heart failure. And if this is not corrected properly, it's going to cause end-stage heart disease and lead to death. Now, the latest guidelines, the guidelines from the European Society of Hypertension, they published guidelines this year, and the classification of hypertension is the same as what we already know, where we divide its hypertension into grades, grade 1, grade 2, grade 3, and then they make mention again of the optimal BP and the normal high BP. Hypertension also can be diagnosed not only by using office blood pressure, but we can use ambulatory BP and home BP measurements to diagnose hypertension. It's important that we take note that when we are using home BP monitoring to diagnose hypertension, we no more use the cutoff of 140/90, but instead we use the BP values of greater than or equal to 135/85 millimeters of mercury. And when we are using the ambulatory BP, the 24-hour average BP, once it is greater than or equal to 130/80 millimeters of mercury, then we say that this patient is hypertensive. Also, it is important not only that we classify the patients into their grades of hypertension, but we also need to stage our patients, whether they're in stage 1, 2, or 3. And patients in stage 1s these are the patients who have uncomplicated hypertension. They have hypertension without hypertension-mediated organ damage. They are not diabetic, they have no cardiovascular disease, and they have chronic kidney disease at a stage less than or equal to 3. Once the patient has diabetes or they have hypertension-mediated organ damage, like left ventricular hypertrophy, for example, then that patient now moves to stage 2. And the patients who have high risk, that is patients who have chronic kidney disease, stage 4 or 5, patients who have cardiovascular disease, like patients who have had a stroke, patients who have had a myocardial infarction and they're hypertensive, they automatically come on the stage 3 hypertension. So the staging is important for us so that we know the risk of our patients and we know how to manage these patients. So we have a hypertensive patient, we need to grade the hypertension and we need to stage these patients. Now a little reminder of the pathophysiology of hypertension. We know that we have 2 types of hypertension. We have the primary hypertension or the essential hypertension, and we have secondary hypertension. We have secondary hypertension where the cause of the hypertension is known. And this we see in just a very small population of the hypertensive patients. The majority of the patients that we see will have essential hypertension. And in essential hypertension, the cause is not really known because we have a complex relationship between multiple factors. we have genetic factors come into play. They interact with multiple environmental factors, which also interact with the aging process. And these interaction of factors, they cause a whole set of abnormalities on our cardiovascular regulatory mechanisms, giving rise in the long run to an increase in our systemic vascular resistance, which is the principal hemodynamic hallmark that we see in patients with hypertension. Recently, we have new environmental factors also that have been identified for causing hypertension. And there we have noise pollution as part of it to also causing hypertension. We know that the RAS system plays a major role in hypertension. And if we remember from medical school, we know that the renin causes angiotensinogen to be converted to angiotensin 1. And then the angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor, which tends to have a lot of pathophysiological consequences, some of which could be beneficial, but some could be very harmful. We know that it promotes the production of two other very potent vasoconstrictors, that is endothelin and the vasopressin. It also stimulates salt and water retention by direct action and also by an increase in the aldosterone. It increases our sympathetic nervous system, and therefore it increases the inotropic effect on the heart. It causes growth of our vascular smooth muscle. It causes our myocyte growth, giving rise to left ventricular hypertrophy, which in the long run is going to give rise to heart failure. Hypertension affects target organs in the body and causes hypertension-mediated organ damage. We know on the blood vessel, it gives rise to vasoconstriction, it causes endothelial dysfunction, it causes atherosclerosis. On the heart, as we said, it gives rise to the left ventricular hypertrophy, which in the long run, as we said earlier, gives not only rise to heart failure, but it also causes arrhythmias. The brain, it causes dementia, it causes stroke, it affects the kidneys, causing proteinuria and renal failure, and it affects the eye, if not treated properly, causing blindness. And if all these consequences of the hypertension is not managed properly, it's going to cause death in these patients. It is important to note that when there is target organ damage, your cardiovascular risk increases. And so it's not the same as just having somebody with just hypertension as compared to somebody with hypertension and left ventricular hypertrophy. So in this slide, the blue bar graphs represents patients with hypertension, and the red represents patients who have hypertension plus left ventricular hypertrophy, which is what, as I said earlier, we see in most of our patients with hypertension. And as you can see, the 2-year age-adjusted incidence of events is much, much greater in patients who have hypertension associated with left ventricular hypertrophy than in patients who just have hypertension. So left ventricular hypertrophy is another major risk factor for cardiovascular disease just on its own. And so, as we said earlier, we need to stage our patients and we need to grade our patients depending on what BPs that they present with, so that we can identify whether the patient is at low, moderate, high, or very high risk. And this risk assessment is going to help us to manage our patients properly. It's going to tell us how aggressive we need to be in our management. It's going to direct us into what target BP we want for our patients. And as we can see, those in red are very high-risk patients. And even some patients who have high normal BP may fall in that red zone, and therefore their BPs need to be lowered in order to reduce their cardiovascular risk. So once we have a patient with hypertension, we go about evaluating them the same way that we learned in medical school. We follow that same process, and that way we will not go round. No shortcuts. So we get the history from the patient, and then we do our physical examination. Always remember that we need fundoscopy as part of our physical examination. So for those of us who have forgotten how to do fundoscopy, we have eye clinics. We have a lot of ophthalmologists, and so we can refer for them to get fundoscopy done. And then there are key investigations that we need always to request for our patients, which I have listed here on the investigations. As you can see, a 12-lead ECG is essential for all our patients with hypertension. We need to find out if these patients have arrhythmias, and we need to detect if there's any signs of left ventricular hypertrophy. As we said, it is a major risk factor for cardiovascular disease. If possible, all these patients should have an echocardiogram done, because an echo has much higher sensitivity when detecting left ventricular hypertrophy. And then we have optional tests depending on the patient's history and physical examination and what the other investigations give us. For example, if we see that we have renal impairment, then we may want to go on and do an ultrasound so that we can evaluate the kidneys further. What are the goals of management of hypertension? Our primary goal is not just to get the BP to target, but our primary goal is to reduce the patient's total cardiovascular risk to minimal. This is our goal for the patient. And so we want to treat the patients according to guidelines recommendation. And so all the guidelines on hypertension recommend that we lower the BP to at least less than 140 over 90 millimeters of mercury. So we can't have the patients come into clinic every day, come for follow-up. We check the BP even when they come to clinic. Our office BP is giving us maybe 145 over 92. They come the next time, 3 months, they have maybe 148 over 90, and then we write for the patient CT, continue treatment. We have to remember, still the patient is not at target. Guidelines recommend a blood pressure lower than 140 over 90 millimeters of mercury. And a target in most patients should be less than 130 over 80 millimeters of mercury. And this target should be really used for nearly all patients, except maybe the frail elderly patients, those more than 80 years, where our target BP should be a bit higher. Again, we have to take into consideration how frail the patients are. So each patient, we have to look at the patient as a whole, as one person. We shouldn't group everybody under the same umbrella. We are not all the same. And so the target for the patient all depends on how strong that elderly patient is and how well they're able to tolerate the BPs. If they can tolerate a blood pressure less than 140 over 90, then we should get them to that level. I think I have lost my slides. So let me get my slides running again. All right, thank you. So let's go back to the next slide. So So according to the European Society of Hypertension guidelines, the treatment of hypertension is with lifestyle modification and drug treatment. And as you can see, all the patients with hypertension should be managed from the beginning, initially with lifestyle intervention and drug treatment, except the patients who have grade 1 hypertension who are at low cardiovascular risk. So all the patients who are in grade 2 hypertension or grade 3 hypertension should be managed from the beginning with lifestyle modifications and drug treatment. And those in grade 1 hypertension whose systolic blood pressure is less than 150 millimeters of mercury and or their diastolic blood pressure is less than or equal to 95 millimeters of mercury, and they have no other cardiovascular risk, they have no other risk factors, they have no hypertension-mediated organ damage, they do not have any cardiovascular disease. These patients are at low risk, and so they can be started on only lifestyle modifications. And after 3 months, if the blood pressure is not controlled, then we start the patient on treatment. So no more do we use that method of initially starting the patients on lifestyle modifications for all the hypertensive patients. As I say, we look at each patient separately when we are trying to manage the patient. And only those with grade 1 hypertension who are at low risk are the ones that we start with lifestyle modifications, and after approximately 3 months, if they are still not well controlled, then we initiate pharmacological treatment. What do the guidelines recommend that we should use to initiate treatment for those patients? So we are using, this is the European Society of Hypertension 2023 guidelines. And they recommend that we initiate treatment for those patients with a RAS blocker that is using either ACE inhibitors or an ARB together with a calcium channel blocker or a thiazide or thiazide-like diuretic for these patients. So this is what we should start, combination therapy for most of our patients. As you can see, though we can initiate treatment with beta blockers, these beta blockers have specific indications as initial drug treatment for the patients. And to go in a little bit more detail, as we see, we start with that treatment that is an ACE inhibitor ARB plus a CCB or diuretic. We usually start at low dose with this dual combination, preferably using this dual combination in a single pill combination. If the blood pressure is still not well controlled, then we increase the dosage of that combination to maximum dosage that the patient can tolerate. If BPs are still not well controlled, then we add a thiazide or thiazide-like diuretic for this patient. And if this patient is on maximum dose of those 3 medications and BPs are still not well controlled, we have to start thinking of resistant hypertension, and then we add maybe beta blocker for that patient or aldosterone inhibitor for that patient. And again, this is the general strategy that we are going to use for the patient. But as I said, each patient we look at separately based on the patient's risk factors that they have. And not only the European Society of Hypertension guidelines recommend this treatment strategy, but also the International Society of Hypertension. In their latest guidelines of 2020, they also recommend dual therapy to initiate treatment for patients, again to starting at low dose. Low dose, again, it depends on what blood pressure that the patient has and whether the patient has hypertension-mediated organ damage. And the drugs that they recommend, we see it's from A plus C, and the drugs in group A are the ACE inhibitors or the ARBs, and the drugs for class in C are the calcium channel blockers. So they recommend that we start treatment with a RAS blocker plus a calcium channel blocker, Also, if the medications are not controlling the BP, maybe after 3 months, we titrate to maximum dose, still we don't have proper control, they too recommend that we add the thiazide or thiazide-like diuretic as the third drug for these patients. And so, as we said in the PAFO phase, the RAS system is a major target for, and the RAS system is a major player when it comes to development of hypertension. And therefore, it must be targeted when we are treating hypertension. So we need to include in our treatment strategy medications that's going to counteract the effect of the RAS system. And so we see the ACE inhibitors, they work at the level of where angiotensin 1 is converted to angiotensin 2, that potent vasoconstrictor, which has a lot of negative effects on the body. And the ARBs, they act at the level of the angiotensin 2, blocking the angiotensin receptors, the AT1 receptors, and therefore they help to avoid, as we said, inflammation, atherosclerosis, thrombosis, fibrosis. There are specific conditions that favor the use of RAS blockers. And so if the patient has if the patient has heart failure, they would benefit from a RAS blocker. After myocardial infarction, to reduce the remodeling of the left ventricle, RAS blockers will be beneficial. Diabetic patients, patients who have proteinuria, patients with left ventricular hypertrophy, those who have AF, and patients with the metabolic syndrome. And as if we can think back at all the clients, the hypertensive patients we see, we will see that most of our patients may have one of these conditions associated with their hypertension. And so most of our patients would benefit from a therapy, drug treatment that has effect on blocking the RAS system. Again, we said that the hypertension is a cardiovascular disease, part of the cardiovascular disease continuum, where not only hypertension is a risk factor, but there are multiple other risk factors which may exist in those patients along with the hypertension. And so we need to treat not only the hypertension, but we need to treat any associated risk factor that the patients may have. And so we may need to add statins depending on what level of LDL these patients have. We may need to add antiplatelets if there's an indication. And if the patient is diabetic, we want to get the HbA1c to target to less than 7% in most of the patients. Now let's look at the benefits of antihypertensive medication beyond the BP control. As we said, our aim of treatment is to reduce the patient's cardiovascular risk. And so let's look at some of the antihypertensive drugs that are beneficial in reducing the cardiovascular risk. And there is a large data, a lot of evidence showing that the ARBs are effective in reducing cardiovascular risk. The ARBs that have been most widely studied is the Telmisartan and valsartan when it comes to studies related to cardiovascular outcomes. And there are studies with telmisartan in more than 50,000 patients when it comes to cardiovascular outcome trials. And so, we are now practicing evidence-based medicine. No more we are saying, what we think, but we use what the evidence says. And there's a lot of data showing that these ARBs are effective in not only controlling the BP, but reducing cardiovascular benefits. And these benefits go beyond just BP control. And so in this meta-analysis that involved data from 4 trials, involving a large number of patients. You see, it involved over 16,000 patients. And there they compared the ARBs with control regimens. And they found out that patients who were treated with ARBs, there was a significant reduction in stroke and heart failure in this group of patients. So those who had ARBs as part of their treatment, their risk of stroke and their risk of heart failure reduced significantly when compared to the other control regimens. Now, there are several ARBs. Even here on our market in Ghana, we have a lot of the ARBs presently available. And it is important to note that not the ARBs, though they belong to the same group, they are not all the same. The pharmacological properties of the ARBs are different. And so we need to take that we need to have that at the back of our mind when we are selecting an ARB for the patients. So when it comes to the structure of the drug, it is different. When it comes to the affinity of the drug to the binding site, when it comes to the half-life of the drug, they are not all the same. And as we know, compliance is a problem with our patients. They want drugs that they can take once a day. And so we need to look for an ARB with a very long half-life. And as you can see on this slide, Telmisartan, which is the last drug here on this list, which is represented by this green bar, it has the longest plasma half-life, a plasma half-life of 24 hours, showing that you are guaranteed to have a 24-hour duration of action when the patient takes Telmisartan. So we know that the drug is going to last into the system for the whole day. So you tell the patient, pop the drug into your mouth in the morning before you go to work. And at least you know that it's going to take you, the action is going to last for 24 hours. Now let's look at specific cardiovascular protection that we get from the ARBs. As we said, Telmisartan has been widely studied, several cardiovascular outcome trials, and so we look at a few of the trials where Telmisartan was used in terms to look at cardiovascular benefits. And the on-target trial was one trial that compared the ARB Telmisartan with the ACE inhibitor ramipril with a combination of both Telmisartan and ramipril. And this drug, there were 3 arms, as you can see. This drug was used in patients who had high vascular risk. So that is patients who had probably coronary artery disease, peripheral artery disease, or cerebrovascular disease, or patients who were diabetic and they had end organ damage. So it included a large number of patients. We see that 8,576 patients were given 80 milligrams of Telmisartan daily. Another 8,542 patients were treated with ramipril 10 milligrams. And then 8,502 patients were treated with both Telmisartan 80 milligrams daily plus ramipril 10 milligrams daily. And these patients were followed up for 56 months. And the cardiovascular endpoints that were being investigated was the composite of cardiovascular death, myocardial infarction, stroke, or hospitalizations from heart failure. And at the end of the trials, the risk of cardiovascular events was similar for patients receiving Telmisartan versus ramipril. The patients who got the combination therapy also had a reduction in their cardiovascular events, but these patients had it was associated with a high incidence of side effects. And as a result, the combination of an ACE inhibitor plus an ARB is not recommended at all because of the increased incidence of side effects. including renal dysfunction. Another study that we have is the Transcend study. And that study, again, was to compare cardiovascular risk in patients who were treated with Telmisartan versus patients who were given placebo. And it was used specifically in patients who were intolerant to ACE inhibitors and patients who also had high vascular risk. That is, patients intolerant to ACE inhibitors who had coronary artery disease or peripheral artery disease or cerebrovascular disease, or the patients who were diabetic with end organ damage. And there were 2 arms, randomized controlled trial, 2 arms of the study. They were treated either with 80 milligrams of telmisartan a day or placebo, again with a follow-up of 56 months. And the primary endpoint of the study was the composite of cardiovascular death, myocardial infarction, stroke, or hospitalizations from heart failure. And in that study, there was no significant difference in the effects of treatment when it came to the primary composite endpoint. But a post hoc analysis was done in the group of patients who were hypertensive compared to the patients who were non-hypertensive. They wanted to find out if telmisartan had any effect when used in patients with hypertensive with those cardiovascular risks, unlike patients who were non-hypertensive. And in that analysis, they found out that telmisartan had a significant risk reduction. The risk reduction was 25% in patients in the development of myocardial infarction compared with placebo. So those hypertensive patients who were treated with telmisartan, the risk of myocardial infarction was 25% less than in patients treated with placebo. Again, left ventricular hypertrophy is important. And so I had to include this slide because, as I said, many of our patients in Ghana have hypertension with left ventricular hypertrophy. And so from the Transcend study, analysis was done also where telmisartan was compared with placebo in terms of the prevalence and the new development of left ventricular hypertrophy. And the patients who were treated with telmisartan at baseline, 12.7% of these patients had left ventricular hypertrophy, and those who were treated with placebo at baseline, 12.8% of those patients had left ventricular hypertrophy. After 2 years and 5 years, left ventricular hypertrophy was again assessed, and they used ECG using the Cornell criteria to assess the presence of left ventricular hypertrophy. And as we can see in the diagram on the left, patients who were treated with telmisartan, after 2 years, 10.5% of the patients had left ventricular hypertrophy. And those who were treated with placebo at the end of 2 years, 12.7% of these patients had left ventricular hypertrophy. And then after 5 years, those treated with telmisartan, 9.8% of the patients had left ventricular hypertrophy compared to 12.8% in those treated with placebo, showing that telmisartan reduces the risk of left ventricular hypertrophy. And the overall reduction was 21% reduction in left ventricular hypertrophy risk with telmisartan compared to placebo. Analysis again with that study also showed a 37% reduction in left ventricular hypertrophy risk at follow-up with telmisartan versus placebo. So it reduced the prevalence of the hypertension, of left ventricular hypertrophy, and it also reduced the development of new left ventricular hypertrophy in these patients. So left ventricular hypertrophy is reversible if it is properly managed. Nowadays, diabetes is considered as a cardiovascular disease. And so we need to also take into consideration diabetes as cardiologists. And so we also want to look at studies that talked about the new onset of diabetes. So you know there are certain drugs that tend to increase the probability of patients developing hypertension in comparison to other drugs. And so in this network meta-analysis that was done to demonstrate which group of drugs is more associated with the development of diabetes. And so the ARBs, the ACE inhibitors, the CCBs, placebo, beta blockers, and diuretics were compared. And the diuretic regimen was used as reference in this meta-analysis. And as we can clearly see from these results in this meta-analysis, the ARBs and the ACE inhibitors are the antihypertensive agents that are least associated with incident diabetes. So these are the drugs that are less likely to cause the development of diabetes when used in patients. Again, I'm just demonstrating here the cardiovascular continuum. You know, as we said, it starts with risk factors, with hypertension being a major risk factor. Other risk factors, diabetes, obesity, elderly, that, as we said, give rise to atherosclerosis, and in the long run, is going to cause heart failure and death. And so, Telmisartan has been extensively studied at different aspects of the cardiovascular continuum. There are several studies that demonstrate the benefits of using telmisartan and in reducing the progression of the disease in the cardiovascular continuum. And we're just trying to demonstrate that in this slide. Again, just a reminder, once we have diagnosed our patients with hypertension, guidelines recommend that we initiate treatment with a 2-drug combination, preferably in a single pill. And they have recommended that we start with a RAS blocker plus CCB, or we start with a RAS blocker plus a thiazide or thiazide-like diuretic. And a very good combination that we can use is a calcium channel blocker plus an ARB combination. And why we think this is a very good combination? Because of the synergies that we get with these two drugs. Their effects counteract each other. We know that the calcium channel blockers, they cause arteriodilatation. The ARBs cause venodilatation. The CCBs can give rise to peripheral edema, whereas the ARBs attenuate peripheral edema. And so if we combine those two drugs, we get not only arteriodilatation, but we got venodilatation, and the effects of getting peripheral edema, as we see with the calcium channel blocker, is reduced when the CCB is combined with an ARB. We get better blood pressure control and we get less side effects because of this synergetic effect of these two medications when used together. Again, we are practicing evidence-based medicine. We need to show the data, and from the data, then we decide. And so, as we said earlier, there are several studies with telmisartan in several risk groups of patients. So telmisartan has been studied in patients with hypertension plus diabetes, patients who are obese, patients who have metabolic syndrome, the elderly patients, the Black patients. And in all these group of patients, they have demonstrated a consistent and significant reduction in the blood pressure in these hypertensive patients. And so in conclusion, we can say that hypertension is the main driving force behind the high cardiovascular disease, morbidity, and mortality. Guidelines recommend that we initiate treatment with dual therapy, preferably in a single pill combination using an ACE inhibitor or ARB plus a calcium channel blocker or a fireside-like diuretic in most patients. Cardiovascular and renal events are most effectively prevented not by simply reducing the high BP in isolation, but by improving several risk factors at the same time. The ARBs have been shown to be beneficial throughout the cardiovascular disease continuum. And the combination of ARB plus amlodipine in the single pill therapy has shown to be very good in controlling BP and reducing side effects. Thank you very much for your attention. Hello?
Hello, can you hear me, please? Please, can you hear me? Okay, thank you very much. So thank you very much, Dr. Mrs. Jan. Please, it's time for Q&A. So I'll be most grateful if anybody have a question, if anybody have any contribution. This is a scientific forum. Please just push through your questions so that we ask all those questions to Dr. Mrs. Jan to help us address them. Thank you very much. If you want to ask any question, you can unmute your... or you can type in the chat box. Yeah, okay. Dr. Mrs. Jan, please, there's a question here. What is your thought with regard to the use of thiazide diuretics and thiazide-like diuretics in patients, either as monotherapy or in combination with the ACE inhibitors or ARB?
Okay, so as we see from the guidelines, the thiazide-like diuretics can also be used as initial therapy for patients with hypertension, along with the ACE inhibitors and the ARBs. Both of them are recommended, either the fireside or the fireside-like diuretics. And we tend to also get good benefits with these medications. Sometimes the combinations available when it comes to the fireside-like diuretic, the most readily available one in Ghana is the hydrochlorothiazide. And the combination it is associated with in most of the cases is 12.5 milligrams. So we can go ahead and use that in the patients when we initiate in treatment, along with the RAS blocker. The only thing, maybe some of the patients may get some side effects. They may complain at times, especially when they initiate treatment, of an increased frequency of urination. Some patients complain, not all, but we do have a bit of patients. And in patients who may already have some chronic kidney disease, then these fireside and fireside-like diuretics may not be very effective at that stage. And in that case, then we may decide to use the calcium channel blockers. But we can decide to start with anyone in these patients.
Thank you very much. Please kindly type your questions. Okay, so there's a question in what situation can ARB be used as monotherapy?
All right. So as we see guidelines again, we go on guideline-based management. And guidelines recommend for patients who have grade 2 and above hypertension that we initiate treatment with combination therapy. So maybe in the patients who are grade 1 hypertension, where the blood pressure is systolic, is less than 160 millimeters of mercury, and the diastolic BP is less than 100 millimeters of mercury, then we can go ahead and start maybe with an ARB as monotherapy, especially if those patients have other risk factors like they have left ventricular hypertrophy, if the patient is diabetic, if the patient has proteinuria. We could also use it maybe in a diabetic patient who have a high normal BP, and the patient may have other even organ damage. He may have some diabetes with left ventricular hypertrophy, high normal BP. We would want to reduce the BP to less than 130 over 80 in this patient. And so an ARB would be perfect for use in this group of patients.
Thank you very much. There is a question hanging here. As one of our colleagues, when I say one, a doctor, would like to find out about prehypertensives. At what point do you want to put them on medication? At what point? Prehypertensives.
All right. So again, we have to take the prehypertensive individually, and we have to identify the patient's cardiovascular risk. We have to see what other risk factor that patient has. It's very important for us to know. We have to identify if that patient, though she is prehypertensive, they may already have hypertension mediated organ damage. A lot of our patients, when they are diagnosed with hypertension, they already had a stroke, or at the time when the myocardial infarction is diagnosed, that's the time they find out they have hypertension. So this patient here, as you said, has prehypertension. That means they're in the high normal BP, but they may have other risk factors. They may have hypertension mediated organ damage. They may have also chronic kidney disease. These patients may be elderly, more than 60 years, and so we risk that patient. And depending on where this patient falls, high risk, very high risk, and even some moderate risk, we may want to start medications for these patients. And maybe in this group of patients, they may not need combination therapy, single therapy, and an ARB will be a good choice of drug to start for these patients. It's usually well tolerated, and so we may decide to initiate treatment with that medication, starting maybe at a low dose and titrating the dose until the BP is adequate.
Okay, thank you. Thank you very much. Please kindly keep posting your questions. The speaker is with us before she drops off. Please kindly push your questions. Don't be quiet on me. It's an important topic. But Dr. Mizija, let me ask this question. First, I'm asking this question. I have been involved over the years, not just in cardiovascular disease management from the industry perspective, but have also been quite involved extensively in the management of asthma. And over the years, I've noticed that these two diseases in terms of management have not changed so much despite guideline evolution. What really accounts
you know, for that. But where you sit as a cardiologist, what is the issue and what can be done?
When you say the treatment has not changed as much, I am not so clear I understand you.
Well, in terms of intervention, please, drug treatments, yeah.
Okay, okay. So, because the patients are asthmatics, we have to be careful, especially with the use of beta blockers in those patients. So very, very careful with the use of beta blockers. But we need always to get the patient's blood pressure at target. So we need always to bring their BPs down to at least less than 140 over 90. And our aim really is to get it to less than 130 over 80. And again, these patients also require adequate treatment. They require, even if they are asthmatic, we don't withhold the medications from these patients. As I say, certain groups of medications may not be indicated in these patients, but calcium channel blockers can be used in these patients. ARBs or RAS ACE inhibitors can be used in these patients and get these patients' blood pressure to the level that it needs to be. They will also be using the inhalers, salbutamol, which may cause some tachycardia for them. But again, if they are well managed on their steroids, then they shouldn't have so many or maybe so much crisis. And really, we should try to get their blood pressure to normal.
All right, thank you. There's a question here. Please, what is the evidence with regards to the prevention of major adverse cardiovascular event, that is MACE, in terms of using an ARB or ACE inhibitor?
Right. So, as I said during the presentation, we have lots and lots of studies where we use the ARBs, and there are also a lot of trials where the ACE inhibitors have been used and they have been shown to be very, very, very effective in reducing the cardiovascular disease risk. As I mentioned, we have a cardiovascular disease continuum where we have different risk factors modify the heart and other structures in the body, giving rise also to many changes in the body. And these group of drugs, these RAS blockers, have been shown to be very, very effective in reducing those effects. They have been shown particularly to reduce the left ventricular hypertrophy. And we know left ventricular hypertrophy is a major factor of remodeling. This left ventricular hypertrophy, it causes dilatation of your left atrium. Once the left atrium dilates, you are at greater risk of developing arrhythmias. So these patients are likely also now to develop atrial fibrillation. And this therefore puts the patient at a greater risk of heart failure. And then if this heart failure is not properly managed, it puts the patients at risk of end-stage cardiovascular disease and then death. And also, not only does it cause remodeling in the heart, but it causes remodeling in the vascular system. So that's why cerebrovascular disease, that's why peripheral artery disease come into play. And these remodeling, the RAS blockers are very effective in contradicting this remodeling. And so they are effective medications for when it comes to reducing cardiovascular disease risk.
Thank you very much. There's a question here from Kings and Queens Medical University College. Thank you for the presentation. I want to know your take on the use of ARB in stage 3 and above CKD patients.
Okay.
Yeah.
So I'm not a nephrologist, but we know that the ARBs reduce proteinuria. And so they are very effective. Again, these are from trials that have been shown that they are effective in reducing proteinuria. The only thing as a side effect to the ARBs increases the potassium levels. And we know that when it comes to chronic kidney disease, we have to be very careful with the potassium because that's what usually kills the patients, the hyperkalemia that they develop. And so The use of ARBs can be used really in patients with stage 3 chronic kidney disease, but we have to be monitoring our potassium levels. That means these patients need very frequent follow-up. You see, it's unfortunate in our part of the world where medicine is out of pocket. Everybody has to pay for treatment, they pay for their drugs, they pay for the test, they pay for their transportation to come to the clinic because the clinic is so far, maybe from where they live. So it makes management of these patients very difficult because of cost. And because of that, sometimes you're inhibited in the tests that you can do for these patients. You may request, but they will not do. And so you have to weigh the benefits versus the side effects that they may develop. So if we're going to use this ARBs in these patients with chronic kidney disease, we need to monitor their potassium, especially regularly, so that we titrate our dosages based on what our potassium level is.
Thank you very much. There is another question here. Does a CCB ARB combination in any way affect erectile function or otherwise?
So this question really is very important because a lot of the patients is amazing, particularly the male patients. That's their main problem with the medications, main problems. And many of them, especially with the CCDs, they come, doctor, no. Amlodipine there, I don't like. No, nifedipine is not good for me. They don't tell you straight a lot of the times, but when you inquire further, then you find out why they have a problem with this. And the CCBs do have an effect on the erectile function. The ARBs are very good drugs in terms of side effects, minimal side effects. They will not affect erectile function at all, but the CCBs will. But also, it is important to remember many of these patients already have their erectile dysfunction from some other cause. Not always it's the medication causing the problem. They may be diabetic patients and they already have the problem. So we also need to investigate and we need to let them know that it's not always the medication causing it. And even if that combination, because there's CCB, it may cause erectile dysfunction in a small percentage of the patients. But many patients are on this combination with no erectile dysfunction. Everybody is not the same. All patients are not the same. Side effects are there because drug companies will be sued if they don't put in all the side effects. So I always tell the patients, you go ahead, take the medication, see the effect that the medication is having on you before you come complaining of the erectile dysfunction. And many of the patients are on these combinations of the CCBs plus ARBs with no erectile dysfunction. So it should not be something limiting the use of this drug. Please don't limit a very good combination because of your fear of erectile dysfunction. I have many patients on it and there's no erectile dysfunction. Again, too, some of them with the erectile dysfunction, as I say, maybe from other causes, and we can also give them something to help. After investigating them fully, we can give them something to help with their performance.
Thank you very much. Please, any more question? We have a short presentation, very, very short presentation. Any more question? Well, I presume that everybody has fully understood Dr. Mrs. Jan's presentation. I would like to say a very big thank you to Dr. Mrs. Jan. Though she has finished her job now, I will be most grateful if she can still hang on after after that short presentation. Then probably she can live peacefully. So at this venture, I would like to invite Mr. Jonas Santi, who is going to do a short presentation. Thank you very much.
So good evening, ladies and gentlemen. Thanks for your time. And thanks once again to Dr. Mrs. Chan for the excellent, insightful presentation on hypertension and hypertension management with focus on the use of the ARBs. So for Boehringer Ingelheim, we are indeed excited for this opportunity to collaborate with our partners to bring these CPDs to our cherished doctors. What I'll do is just to highlight what options we have when it comes to the choice of pharmacotherapy for treating hypertension. So I'd highlight some of our brands in terms of the combination therapies that we have, where you can find them, just to make it, accessible and affordable for your patients. So Boehringer Ingelheim, like you all know, is a German pharma innovator company. It's a family-owned business. We continue to develop innovator brands and bring value to our patients across the globe. So we focus on three main areas, which includes human pharma, animal health, and also biopharmaceutical contract manufacturing. So we've discussed hypertension extensively. Just to highlight the fact that when it comes to treatment, the recommendations per the ESC still highlights the need for antihypertensive treatments that achieve sustained blood pressure control beyond 24 hours, preferably in a once daily formulation, as well as providing additional benefits, some of which was indeed highlighted in Dr. Mrs. Jan's presentation, focusing on cardiovascular protection as well as agents that are indeed very safe and tolerable. So I think she highlighted a slide like this, maybe in a much different form, but just to highlight the role of ARBs in treatment, either at the first stage, second step, the role of ARBs are vital in dealing with the RAS factor and also getting optimal outcomes for our patients, especially when these hypertensive patients have comorbidities, be it diabetes, be it metabolic syndrome, be it proteinuria, and some of these were indeed highlighted in the presentation. So our brand is called Mycardis, and Telmisartan was innovated by BI. The brand is Mycardis. Mycardis comes in 40 milligram strength and 80 milligram strength. So your lower starting dose would be 40 milligram. Then you can up titrate to 80 milligram for better outcomes. But again, you have the single pill combination for your combination medication. So you have telmisartan plus hydrochlorothiazide, which is 40 12.5. Then you have the 80 milligram telmisartan plus 12.5 hydrochlorothiazide. Indeed, this would be like your baseline starting, medication once you have fully diagnosed an antihypertensive patient for which you want to use an ARB plus a hydrochlorothiazide option. Then we have the ARB plus calcium channel blocker option. So your Telmi plus amlodipine. For that, we have the 85 strength and the 80-10. So 80 Telmi, 5 amlodipine, 80 Telmi, 10 amlodipine. Again, all these are available in all leading pharmacies across the country. And it is our belief that having understood the positioning for these molecules, you would want to use them for optimal outcomes for your patients. Again, this is a slide that was highlighted in Dr. Jan's presentation. It talked about some of the advantages in terms of the pharmacological profile for telmisartan. So here we are seeking to highlight the long half-life, indeed the longest among all the other ARBs you may be using currently. So be it candesartan, irbesartan, valsartan, telmisartan offers you a full 24-hour coverage, and this goes a long way to ensure better blood pressure control all day throughout the day for your patients. Then the other parameters of interest include your receptor affinity. Dr. Jan highlighted the interaction, between uh, the the uh, the agents for blood pressure control. So that interaction affinity is important to get better outcomes. With telmisartan, you have the highest affinity. Then you have tissue penetration, which is important. Last but not the least, the selectivity for the PPR gamma receptor. And this is relatively an interesting one because for all the other ARBs, it's Telmisartan that has the advantage. Now, this receptor gamma is important for insulin as well as fatty acid metabolism, so that for your patients, particularly hypertensive diabetic patients, you have better outcomes if they are on a telmisartan ARB for that matter. So another way of looking at it is through just the numbers, all right? Look at the half-life, 24 hours clear coverage compared to valsartan of 6 hours, candesartan of 9 hours, losartan of 69 hours. Then another parameter of interest could be your volume of distribution at steady state. You have a clear advantage for telmisartan, offering you better concentrations of a drug for blood pressure reduction um, all day throughout the day. And this is up to 500 liters compared to a marginal 0.13 for candesartan, 17 for valsartan, and then you have just about 12 liters for losartan. So these are all things that it will be interesting and important to appreciate, knowing that all ARBs are not the same. And that's why for us, MyCardis is actually the way to go in terms of choosing, the right ARB for your patient. Now, here is yet another slide just highlighting the advantage we have beyond blood pressure reduction in terms of cardiovascular prevention. Dr. John talked about the on target. Again, in the other molecules, such as your valsartan, olmesartan, irbesartan, they do not necessarily translate to these robust cardiovascular prevention. But with telmisartan through the on target, we've been able to demonstrate risks in CV death, in MI, and as well as strokes. And these are things that we are confident that your patients would benefit once they are initiated on MyCardis. So MyCardis is positioned particularly for patients with stage 1 hypertension. MyCardis preferably for your uncontrolled patients, those that are not controlled with monotherapy, and also for patients that have some level of fluid overload, be it peripheral edema, congestive heart failure, because again the diuretic effect would result in dealing with the fluid overload. Then you have your MyCardis, your Twin Star, which is the combination of telmisartan plus amlodipine, ensuring that your stage 2 hypertensive patients, severe cases are better controlled. And then your comorbidities, CKD, diabetes, metabolic syndrome, because then again, you have powerful reductions in addition to the ARB effect. And again, Twin Star is something we really want to highlight in this presentation because it's one of the less known, brands. It's available in Ghana. It's really working well in our hypertensive diabetic patients. And we want you to have a patient on it just to see the wonderful outcomes you would have for these patients. So with Twin Star, you're combining amlodipine. A lot of our prescribers are very familiar with amlodipine. The CCB still work in our Black population patients. Here, you're combining it with all the good things that we've learned about telmisartan today, based on its long half-life, based on its receptor affinity, based on its, affinity to the PPR gamma, etc. So here again, you have two classes of medications that work very well to deliver excellent blood pressure control for our patients, particularly beyond just the BP numbers. So with the severest of cases, you are able to see very good drops, all right? And again, normally these drops are tailored, to the kind of blood pressures that you're dealing with up to a 50 millimeter drop in your severest of cases. So mind you, you must be dealing with very high pressures, you know, in initiating some of these molecules in order not to have other, problems. So what are we saying? What we are saying is for BI, we are confident in our brands. MyCardis, we have highlighted is your Telmi hydrochlorothiazide. It provides greater BP lowering in high risk obese patients. It's effective, including your early morning blood pressure surge because of the long half-life and coverage. Tolerability is good as well as adherence. So Telmisartan is something that we want to recommend to you. Comicardis particularly. Then you have Twin Star. Twin Star Telmi plus amlodipine works particularly for your much higher blood pressures. Also gives you effective reduction in proteinuria in your patients with type 2 diabetes, prevents transition to overt nephropathy, and overall reduce your cardiovascular risks. All right. And let's not forget that particularly with the ARBs, there's no challenges with ACE-related cough, which could be a problem if your patients are on selected ACE inhibitors. So we are saying that beyond the numbers, and Dr. Jan beautifully highlighted beyond the numbers the advantages that we are offering you with our excellent ARB. So here you have strong organ protection, you have better treatment compliance, and overall the objective is to reduce the cardiovascular risks of our hypertensive patients, to quote Dr. Jan. And this is what we're seeking to do with our brands. So Tell Me is available on the market at NS Chemist, all the leading wholesalers of NS Chemist, as well as Ozone's Chemist, and then all the leading outlets. Beyond Telmisartan, we're excited to say that we are the faces behind Jardiance, which is your SGLT2 for type 2 diabetes. We're getting a lot of support for Jardiance. We want to entreat you to continue to use it for your type 2 diabetics. We would soon be introducing, or we have indeed introduced Sinjadi on the market as well. Sinjadi is your Jardiance, which is Emperor plus metformin in 4 SKUs. So we'll definitely come to you on that as well. So these are the brands in terms of our cardiovascular portfolio in all. And we want to say a big thank you for your attention. I'll end at this stage and over to the moderator. Thank you to our listeners.
Very much, Jonah Asante. I don't know where Dr. Mrs. Dan is still online. Doc, please, are you still online? Is Dr. Mrs. Jan still online, please? We have one or two questions for her. We are trying to get hold of Mrs. Jan. Doc, are you still online, please? Do we please have Dr. Mrs. Jan online?
Yes, hello.
Oh, okay. Right. I thought we are done with you, and then 3 questions just popped. I think 3. Is it 3 questions? Yeah. Well, one is thanks for the presentation. In the event where BP drop below 120/80 on the combination therapy of CCB and ARB, which one do you recommend to withdrawn? That is one of the questions being put to you. So over to
All
you,
right.
Dr. Mrs. Jan.
All right. Thank you, Jonah. So again, if the BP drops, then we need to reduce the medication. It all depends on what dosage, excuse me, it all depends on what dosage that the patient was on. So if the patient was on the maximum dose and the BP drops to less than 120/80, we don't want the blood pressure systolic going below 120. Preferably, we would prefer it. The diastolic BP can go below 80. Actually, if we go to 70, is even excellent for the patient, unless the patient is elderly and is not tolerating the BP. So again, as I said, it depends on how low the blood pressure goes. It depends on the dosage that the patient was taking. So if the patient was on the maximum dose, maybe 10 amlodipine, telmisartan 80, you may want to reduce to 5 amlodipine, 40 telmisartan. If the patient was on the 540 combination and the BP is going too low, then you may just have to stop the medications and observe exactly what is happening. Sometimes the BP drops. Maybe you have to find out if there's something else that the patient is doing, or if now they have improved their lifestyle changes, if now the patient may have lost weight, exercising regularly, and that is probably why the BP has dropped. So you need to examine and see exactly what is causing the drop, reduce the medicine, and observe how the blood pressure with home BP monitoring, observe what happens to the blood pressure.
Thank you very much. There are two questions here. I will hand over to Jonas Santi to address. Which brand of Telmisartan or Telmisartan stroke amlodipine are available in Ghana? What are the prices? And then, please, what is the dosing?
Yeah, so thank you very much for the questions. Regarding the brands, I think I've just highlighted the innovator brand, which is Mycardis. So Mycardis 40 milligram is our starting dose. And then we have the Mycardis 80 milligram. We also have the cool Mycardis, which is Telmi plus hydrochlorothiazide. So 40 12.5, 80 12.5. And then we have Twin Star. So we have Twin Star 85, Twin Star 80 10. I also do know there are a number of generics on the market, but I'm unable to speak to them at this point. Regarding the pricing, what I would say is we have very competitive price in terms of ARB innovator to ARB, ranging between 220 to 230 for Mycardis, co-Mycardis. Twin Star is a bit higher, which is 280. And these are wholesale prices for your patients. Thank you. Indeed, the retail prices would have a 30 to 40% markup, depending on which retail outlet you're at. Thank you. Do I answer the dosing question or doctor? Okay, so regarding the dosing, all these medications are once daily dosing. Be it Mycardis, cool Mycardis, or Twin Star. I mean, we all know about that long half-life. So it allows for once daily dosing, preferably in the mornings for these patients. Thank you very much. Over to the moderator.
Thank you very much, Mr. Asante. Dr. Mr. Jan, there is a question here for you, and I think that should be the last question. I'm trying to understand the question, but let me see if I can paraphrase it. So please, if that's your question, forgive me, from Jennifer. The question seems to seek whether statins are indicated to reduce cardiovascular risks.
Okay, so indications of starting to reduce cardiovascular risk. Well, as we said, we have to see the patient as a whole, and we need to manage all the risk factors that the patient may have. And so we take into consideration particularly their LDL levels. So lipid profile should also always be done. And then we look at the patient LDL level. And the level of LDL you want to get the patient to depends really on where we are starting from and the patient's risk factors. So if the patient is known to have cardiovascular disease, that is patients who had myocardial infarction, these patients or the patient has cerebrovascular disease, the patient have had a stroke before, the patient has peripheral artery disease, the patient is known to have aortic atherosclerosis, maybe from doing any imaging test and you find out there's significant atherosclerotic along the aorta, any part of the aorta, then you would want to get the LDL level to at least less than 1.4, less than 1.5. You want to reduce the LDL level to at least 50%. So your target is to bring the LDL as low as possible to reduce their cardiovascular risk. And if the patient is at moderate risk so these patients who are moderate or high risk, then you would want to reduce the L level by about 30 to 50%. And so your target LDL for this patient maybe will be about 1.8 to about 2.6 millimoles per liter for this patient. So again, it depends on the other risk factors that the patient has and what risk group that patient falls in, the level of LDL you want to get them at. I hope I have answered your question.
Yes. So thank you very much to our audience. We want to thank you for making the time for this evening's presentation. I would also want to thank our guest presenter and speaker, Dr. Mrs. John, cardiologist with the National Cardiothoracic Center, for taking time off her schedule. She's a very busy doctor, for making time to present on hypertension and its management, as well as taking us through the different, options, guidelines, and best practice. So what I would also at this point would extend gratitude to the platforms and also to our partner, to our partner Britannia Medical Centre. Thank you so much for coming on board. Thank you, Dr. Baini. Would also want to thank the platform CES for making this interaction very possible. I hope we are leaving this session with, all the tools to manage our patients effectively when it comes to blood pressure, which is really on the rise among the populace. Of course, we are all preview to the economic situation. The stress is everywhere, but with the right interventions, I'm sure we'll make progress. So thank you very much, and wish you the best of the evening. Enjoy your evening from BI. Thank you, and we'll be following up on this discussion in your consulting rooms and in other places. Enjoy your evening. Thank you.
Thank you. Bye.
Bye. Thank you, everyone. Bye.